since the early days of EHR implementation, this is probably the largest single-scale impact to the delivery of patient care, how and when and why we integrate virtual services. So in this role, I'm so very fortunate to be part of those conversations every day.
Dr. Christine Gall, thanks so much for hopping on today's podcast, and excited to speak to you about your work at Collette Health. From what I understand, you're the chief nursing officer there, and you have a wealth of experience yourself working at the health system level and leading different technology initiatives. And you've done it all at every level of nursing, from the bedside to executive roles. Can we start by you filling us in on what drew you to virtual nursing, and how did your path lead to Collette Health?
First of all, Bert, thanks so much for the invitation to be here on the podcast today. And to all the nurses listening out there, happy Nurses Month. As a fellow colleague nurse, this is the time of year when we have to celebrate each other. So very happy to do that. And to answer your question, it's funny. I think about my career kind of in three different phases. In the first phase, it was all about learning everything I could clinically, working in different care settings, went quickly back and got a master's degree so that I could enter leadership. And I had the absolute great fortune to work at a facility that was one of the earliest magnet recognized facilities and has kept and maintained their concurrent magnet recognition throughout all of these years. So I grew up in amongst some incredible leaders and incredible clinicians as well. And so during that phase, I had huge opportunities to learn and to lead. I took care of some of the most critically ill kids that there were, recognized that there were some gaps in care that were happening as we were continuing to make breakthroughs and save more kids. The community resources available weren't available to them. So at a later phase, when I got into leadership, I was able to actually, with the support of my CEO and CNO, develop a program specifically customized to allow medically fragile and technology dependent kids into the home where they could be cared for, and go then to centers that were specifically developed to take care of them and their needs, just like their brothers and sisters went to school. So this was an incredible thing. I've spent time in hematology, oncology, and transplant as the service line director, started a new satellite hospital in northern Wisconsin. So I've had lots of exposure to different elements of care, inpatient, outpatient, as well as home care. I also had the ability to start new programs while at the hospital campus in Milwaukee, Children's Wisconsin. I was the first night administrator. So started that role. So in that role, got into things like patient placement, flow, bottlenecks from addressing any administrative challenges overnight. So again, really a wide breadth of experience operationally and clinically. The next phase was in where I really looked at best practice identification and how you used that information to scale across organizations and systems. So I had three distinct roles there. One was, again, at Children's Wisconsin as the director of the National Outcome Center. We had a program along with other national colleagues called the VPS, which is a database for pediatric ICUs. And in that, we learned my team was responsible for doing all the analytics, reporting, development of reports that were sent to executives to look at who was doing care the best. And then we would work nationally across our consortiums to drive improvement in the quality of care for all hospitalized children in the country. So that was exciting. Got a doctorate along the way there, defended my dissertation in 2014 in mass casualty pandemic. So that came into play again a little bit later. I then pivoted into patient experience because that was really, in my mind, the emerging trend in the alignment of patient safety, patient quality, and the voice of the patient, which in pediatrics was always front and center. And I think in the adult world, patient experience was how that idea and concept elevated. So first moved to Denver, worked at SCL Health. And then, so I learned about critical access hospitals, as well as how in Denver they were taking care of a huge population of homeless people and all of their needs as well. And then lastly, in that phase of my career was I worked at HCA, which is the largest health system in the country, responsible for 67 hospitals across 5 divisions, and really understood how scaling a concept or a program, you needed to do it in a very intentional, purposeful way in order to ensure the quality standard reflected across all care settings, et cetera.
Yeah.
So yeah, that was the middle phase. And then currently I'm in what I'm kind of calling my population health phase, looking at, since the pandemic, the need to redesign the way we deliver care has become paramount in my mind. And that's the front and center issue, and how we leverage technology and when, and how we bring resources to the bedside, if not physically, virtually, is really the question of the day. So in my current role at Collette Health, we have the opportunity to engage with leaders who are discussing this issue, learning from each other, implementing programs. So I'm incredibly fortunate. I think since the early days of EHR implementation, this is probably the largest single scale impact to the delivery of patient care. How and when and why we integrate virtual services. So in this role, I'm so very fortunate to be part of those conversations every day.
Yeah. Spot on. And, I'm very impressed by the breadth and depth of your experience, not just leading, but like you said, scaling different operational and clinical initiatives across systems. Cause like you said, like patient populations will vary by facility or site, right? So like being able to understand at a population level how to scale things out is important. And you've clearly done that in your career. And now it brings us to virtual services and virtual nursing, right? Which I know is a big part of what you guys do at Collette Health. And this is something you and I know we started to talk about it, has started to grow rapidly in the recent years. There's examples of, like you've worked at one, like magnet accredited hospitals that are leading these initiatives. How do you define virtual nursing, and what does a strong virtual nursing model look like in practice?
Well, that's a great question. And the question, if you asked 10 people, you're probably going to get 10 variations of the answer. But here's the thing. While I don't think any two virtual nursing programs or virtual care programs are exactly the same, there are foundational things that are important for any successful program. And in my mind, it starts on the inpatient side. I see the virtual care program as a continuum, starting out with virtual observation, which is where you have non-licensed personnel that are extending the eyes and ears of the clinical team at the bedside by virtually monitoring a panel of patients simultaneously, engaging with identifying needs proactively to better arm the bedside staff whenever they go into that room with each touch point with better observations and better understanding what the patient needs, and obviously creating a safe environment where there is no preventable harm that's happening. So that's observation. Then the next stage typically is virtual nursing. It's definitely a much more complex service to provide because, as you and I talked earlier, nursing touches virtually every other department in the hospital. So if you embark on a nursing workflow redesign, it's not just impacting nurses, it's impacting everybody from the admitting department to physician consultants to radiology to lab to everybody. And so doing something like this, and we have not overhauled the model of care delivery in this country for several decades. So this is really an important experience. Once organizations have gotten to a place where they feel that they understand how to implement at scale at the nursing level, they can bring in other disciplines to bring in additional resources to the bedside. In some organizations, it's interesting. I hear, right now we're okay with our nursing. It's not our nursing workforce that's the issue, but we have problems with our PTOT, speech, respiratory services. We don't have enough of those. Or another area might be the nursing assistants or care partners or care techs, whatever you call them. They're just not staying in role long enough. So looking at how those services are delivered and how you might augment care at the bedside and reduce delays. The other thing that's important, I think, for virtual care to solve is how do you prevent delays from happening in the, continuation of care because, that person is busy doing X over here, or that consultant who the hospitalist said, this patient can go home as soon as the cardiologist sees them, and they're busy in clinic all day until 6 o'clock. So if they could check in on that patient virtually at noon, what a better opportunity. So that continuum reflects the inpatient side of care. On the outpatient side of care, the defining this includes things like the major goal on that side is keeping people in their homes or at the lowest level of care possible. So this is where you'll hear telemedicine, you'll hear things like hospital care at home. This is where remote patient monitoring and chronic disease management come in, bringing in other disciplines into the conversation, and definitely applying technology at the right time with the right population, because not everybody is tech savvy. So making sure that the technology matches the abilities of the persons who are going to be using it is really important. So looking at that overall picture is really where we're talking about care. But when we talked up front at the top of this conversation that while there's lots of interest, everybody's talking about this, very few have really been able to say, yeah, we've got this, we have it down, we know what we're doing, it's hardwired. I think there's a couple of reasons for that for the most part. Number one, healthcare generally as an industry is seen as a group that is not typically the early adopters to innovation. Instead, and that's not intended to be, a negative comment, we're most comfortable working in areas that are well researched, that there's evidence, that there is the best practices have been studied and by peer review have, we all consent and we agree that that's the best path forward. And obviously that's an important style, because we're not talking about an error in a production line where, this widget didn't work and it didn't. We're talking about real lives. We're talking about pain. We're talking about mortality, morbidity. So it's very important that we have that caution. But the second factor, and I think it lends back to the complexity that I spoke about earlier, there's no one size fits all when it comes to virtual nursing. Yes, there are foundational elements, but every hospital has their own unique brand. They've developed their own unique corporate culture, and every patient population in each hospital is exceptional, unto their own. So that ensures and requires that every virtual care program needs to address things really uniquely. So I have a few points if you'd like to know my thoughts about how you manage that uncertainty. I have kind of like 10-ish steps or 10 ideas.
Yeah,
do you like me to share?
Yeah, of course.
Okay.
Yeah.
So the first is, it's really important, because nursing care delivery is so complex, to bring in all of the voices, the stakeholders who are going to be touched by the impact of the change in care delivery, to help define the vision, which is the long-term aspirations, along with the goals, which are those mile markers along the way that help you determine whether the course you decided to chart is actually what's happening, or if you need to course correct. We also need to make sure that measures of success are clearly defined, and that executives who are responsible for the approval and the budget and the resources necessary are buying into the whole strategy. Next, the voice of the bedside nurse. I cannot underscore enough that if they are not involved at every single step of the process, because they are going to be the ones that are carrying the burden of making the changes to implementing a virtual care program. If they do not buy in, and if they do not feel that the strategies that have been adopted are going to work, they will be the quickest source of failure. And it's not intentional, certainly. We all are resistant to change if we don't feel that change is positive. And what I like to comment, and I always get lots of head nods and people agreeing, sadly, but I think we've all, if we've been in healthcare for a while, we have that drawer, that closet, or that room that is the technology graveyards of great ideas that have been poorly implemented. And again, if you don't have the voices involved from day one and buy in incrementally throughout the process, virtual care can easily become part of that unfortunate space.
Yeah, spot on. I mean, it's a testament to the work you've done, and it's clear that you understand that this virtual nursing model takes the whole team effort from the inpatient side, like you started to talk about, right? To, hey, what do we currently have already? Because some hospitals, health systems out there may already use some combinations of virtual assistants, techs.
Exactly.
You need their voices in the picture, and then there's also the outpatient side of it, right? Like, okay, once this patient is discharged in the home, how do we enable them with the right virtual mix of telemedicine? There's hospital care programs, RPM, CCM, so it really takes the whole like care continuum, like you mentioned, from the inpatient all the way to outpatient to make a strong virtual nursing model. And that looks different, like, because one hospital or health system may have a completely different nursing model than another. And, what is the alternative, right, without nursing model? And you probably can relate to this, is in the industry right now, there's a huge shortage of nurses, right? Like there's a reliance on locum tenens, right? Like the hospital or health system will have to go to like another zip code or geography to hire an equivalent nurse. And it ends up, and not that they don't provide equivalent value of care, like they often do, then they go through training, but it's a strain on the system because they have to go outside of their normal market and sometimes pay additional for a nurse that provides the same skill, So
Yeah.
that's the flip side of not having a strong virtual nursing model, is you essentially continue to rely on that.
My time in patient experience really helped me understand the impact of mission, vision, and organizational culture on the quality of care delivered. And by design, if you have people coming in and out of that model of care, delivering care in 13-week increments, which is usually the duration of a contract nurse, they cannot buy into the culture. They cannot become part of the culture. It's just not possible to do that. And I think that's one of the challenges when we have so much turbulence in staffing. It really is impacting that. And that needs to be, as you're looking at the measures for success, understanding what all impacts the things that we measure as quality standards and the mark of an excellent versus an okay, or substandard organization are those true human factors.
Yeah, spot on. A big part of this is also like amplifying the human connection, like you said, the patient experience. And from what I understand, you guys have a platform at Collette Health that's designed to do that and not replace nurses or staff, But how do you balance this like AI enabled technology or just technology with the human side of care, especially in these like high acuity settings like you threw out in the hospital or health system,
Yeah. So, I think it's so very important to realize that whenever you introduce technology, hopefully the goal always remains that you are trying to improve the human experience. Obviously, there are other measures along the way. There are financial measures, there's operational measures. But if at the end of the day, you've replaced a positive with a neutral or a negative experience, you really haven't done well. I'm really excited about what AI can do. In my career in the middle data aggregation and analytics phase, we did a lot of predictive modeling where we'd take large data sets. Big data was the catchword of the day, and we would develop algorithms that would help clinicians anticipate and predict care in groups of patients so that they could better decide how to take care of patients. Well, AI, in my mind, is that whole concept on steroids because it's basically creating a model and then revising it, developing it, retraining it, making it better with every successive feed of data. So it's a continually evolving, growing, breathing kind of being. So there are incredible opportunities there. We can actually reduce the amount of, work that nobody likes to do, the repetitive low-level tasks, we can definitely streamline that so that our clinicians, our nurses can be practicing at the top of their knowledge and expertise at the bedside where they want to be, instead of, spending 40, 50, 60% of their day charting in an administrative
Yeah.
tasks.
Yeah.
But,
Crazy.
the other side of that is there's great responsibility, because one error in logic entered into that AI algorithm could, exponentially impact the overall outcome and ultimately lead to a result that isn't positive. So having the governance and the oversight of those processes, as well as, again, the input from the folks that will be asked to be utilizing those tools and techniques, and maybe the algorithms that will advise them on advanced clinical support decision making. It's very important that they have the buy-in and trust in that as well.
Yeah, spot on. So it sounds like you guys provide like sort of a blend of like advisory services so that they can understand like if they're already on this path of virtual nursing, right? Okay,
Mhm.
what are the things I can be doing better? If they haven't started the path, you guys can provide that level of advisory yourself and service, but you also have the
Yes.
technology to enable the model itself,
If we're starting in the virtual observation point of the journey, which I spoke about earlier, we're really looking at trying to help our organizations. This is where using the scale or the one-to-many approach is going to help. So if we are replacing one-on-one sitters that are one-to-one in every patient room that is an at-risk patient with one virtual observer that can watch up to 10 or 12 or even up to 16 patients safely and protect them from harm, because we have introduced AI tools that allow them to keep their face on camera, watching every patient, not having to look down to document or look over here to access something else, that they have point and click opportunities to make sure that it's reflective of what they're observing without taking eyes off of their patients. That's what we're able to do. The virtual nursing side, it really is, we are side by side consultants, not only giving them the communication technology to interact with patients virtually or interact with other members of the care team, but also advise on what we know is happening out there in the rest of the country and how you actually implement a virtual nursing program. Meanwhile, I have my product team back in the office who listens to all of the feedback that me and my colleagues are giving them from the field, and they are refining and revising our product roadmap every day, so that, as an example, we can do things like allow a clinician virtually to share information with a patient, either a video or a PowerPoint, walk them through uninterrupted so that they can be assured that that patient understands what they need to do to be successful when they leave the hospital and transition back to home. Just a tiny example, but I think the things that Collette Health is most recognized for is our agility to quickly address the emerging needs in the market.
Yeah. And on that point, I want to ask you, like, what are some of the biggest like misconceptions or like challenges like hospitals face when implementing virtual nursing? Is it this misconception that, like, yes, the end goal is to get to a virtual nursing model that touches inpatient, outpatient, but like, is it really like, hey, you can start in one of the areas, like inpatient, and then really tackle sitters, right? And virtual observations. When you get that down, then we'll build out the outpatient. Like what are, I'm just throwing an example out there, but what are some of
Yeah.
the biggest misconceptions or challenges you see hospitals face
Yeah.
when they implement this,
That's a great question. It's something that I'm really proud of where we've positioned ourselves at Collette Health, because when organizations start their virtual care journey and virtual observation, and they're able to take the work of 12 people who were sitting one-on-one in patient rooms, sometimes patient care assistants, but sometimes nurses, because they don't have enough of the other type of individual. It's really a drain. But when you're able to allow 11 of those 12 to go back into full assignments and taking care of their patients and managing all of the needs rather than burdening just a handful of the remaining folks with everything that needs to be done, care is elevated, safety is improved, quality and outcomes and experience of care also increase. But that is exactly where the cost savings comes in, because when you're able to do that, you're not paying somebody double time, or you're not paying a contract labor nurse or other professional to come in at a premium pay. You can keep your staff at the level of service, at the right acuity and ratio of patients to staff. And so that is managed. Meanwhile, the savings that you have from from not having all of those one-on-ones, it pays for the equipment itself. And here's, I think, the beauty. In our organization, once you've purchased the equipment you need for virtual observation, when you decide to transition to virtual nursing, it's the same equipment. There's no additional need to buy something new, to pay for another feature. We have all the features available, and our customers today that use us for virtual observation, tomorrow if I get a call, hey, Christine, I want to start virtual nursing. We'll talk about what they want to do. I'll tell them which features we need to turn on, and at no additional cost, they can start their pilots. So I think that's a huge critical feature when it comes to looking at the partner that you want to work with as you enter the care journey. And I really appreciate that question, because I think it's important.
Yeah, no, right on. And when you say it's same equipment as virtual observations as virtual nursing, you mean like on the outpatient side?
Just to be real clear, most of our customers today are inpatient. When you gave me the question about virtual care overall, I kind of gave the high level landscape.
Got it.
But
Okay.
where we are really today is primarily in helping organizations address the pain points that are the greatest challenges to the stability and financial ability of the hospitals and health systems to manage the needs of their patients.
And that's probably where they struggle the most, because a lot of like the telemedicine like technologies out there, telehealth, have been around for a while on the outpatient side, but it's really cracking the code on the inpatient side. Like how do you scale that model to your inpatient staff? Like that's the sweet spot, because if you have both, amazing, but like sometimes you I don't know what you see, but I would venture to say you probably see more organizations that have less of the inpatient virtual nursing baked out and more outpatient, focused. Yeah.
To get back to your question about some of the other misunderstandings or what people might expect from virtual nursing, I hear frequently from some of my nursing colleagues that, their financial colleagues are saying, well, if this isn't going to reduce overall FTEs, why would we want to do it? Well, when you think about the demands on a bedside nurse, here are a few things to think about. Number one, the acuity of patients is skyrocketing. They're coming in sicker than ever before. Patients that would have been admitted 10 years ago never hit the hospital door today. They're managed in a different setting. So, what's left are patients that are really, really sick. At the same time, you have a nursing workforce that is increasingly less tenured. And that doesn't necessarily mean age, but it means experience. When I started nursing, I think the average tenure of the nurses around me that helped me become the nurse I am today was like 18 years. Today, when I'm going around the country, I hear 2.5, 3 years is the average tenure of the entire nursing workforce at the bedside. Yeah. You cannot possibly have the same level of expertise and the ability to anticipate the needs of patients with, those two groups. They cannot be the same. So when you take a senior nurse who might have been in their profession for 20 years and replace them with a new grad, if that's the common way of doing things, you're going to quickly have a knowledge drain. And this is another area where virtual care, while not reducing the number of staff at the bedside, if you can retain the expertise of the person who otherwise was going to leave the profession altogether by keeping them in a virtual role that they can manage physically, mentally, it works with the rest of their lifestyle. That is a win-win all the way around. So we have to stop looking at those easy, quick indicators when we're looking at metrics for success for virtual nursing, like, is it reducing FTEs overall? Looking at things like nursing turnover, vacancy rate, use of contract labor. On the operations side, are we reducing barriers to or delays in care that therefore reduce length of stay, therefore can improve reimbursement? These are all related things, and we have to get much better at taking things that are in different cost centers and bringing them together to paint the real picture of where the savings is happening.
Yeah, spot on. I think you're speaking directly to the core of the matter. It's like any investment into virtual nursing will require understanding what that business case is, whether it's reliance on contract labor, turnover, like all these things,
Right.
issues that are impacting a lot of hospitals are out there, and or retaining the expertise of senior nurses. Like that's important too. Like their knowledge base is immense. Like they know the patient population, they understand the system and technology. And so my last question for you, Christine, is like, as we recognize National Nurses Month, this is National Nurses Month, what is your message to like healthcare leaders thinking about the future of nursing, and how can they begin like exploring or even scaling virtual care, whether that's like virtual observations or virtual nursing with you guys?
Yeah, well, I think that the world of the chief nursing officer and leaders of nursing, as well as the bedside nurses, have never been more challenging than it is today. And I recognize that things that I dealt with in when I was in the trenches in operational leadership are just exponentially less than what's happening today. So it's really important that you partner with somebody who's going to not be there just for the sale, but they are there to walk side by side with you in your journey. I joined Collette Health because I recognize that not only do we have the right hardware and technology solution, but we have an agile team who's all about solving the next problem that evolves, that emerges on the scene, and making sure that we are there not only to support what our customer colleagues are doing, but help lead the way with them. Because we have lots of expertise ourselves in where things are headed. I spend a lot of my time not only in podcasts and things that are able to share information across the industry, but also in building tools and consulting with the organizations and the leaders that we work with. So I have probably one of the best jobs in the world, to be honest. It's so fortunate to be at the forefront of these conversations. And what I will say is I think that the yardstick for which the leaders that are leading today are going to be measured against is the degree to which we are able to redesign nursing workflows in a way that integrate technology and virtual services seamlessly, painlessly, in a way that supports not only the experience of patients and families, but also the care teams that deliver care themselves. So I find this to be the most beneficial place to be, and I'm so lucky and fortunate to be here.
Yeah, that's well said. And I'm sure, in you speaking to other healthcare leaders, they appreciate that you come from a similar background as them. You've led initiatives, you scaled initiatives, and now you have a very firm understanding of like, these are the types of models. This is where you can get started, or, these are the different options for you, right? So I'm sure they appreciate your level of experience and the acumen you bring, to the table. So, and with that said, I appreciate your level of acumen you brought to today's podcast, and it was a pleasure speaking to you. And I will definitely have to, stay in touch on Collette Health's journey as the future of nursing continues to evolve in front of our eyes, and it's something that will impact every health system and hospital out there, right? Like we do need to better support our nurses because they are very overworked, and there's a huge reliance on them and not enough supply, right? So I'm sure this technology and your guys' technology and the market will continue to evolve over the next couple of years.
Bert, I'd like to thank you for the opportunity to spend this time with you today. And for anybody listening to this podcast, if you'd like to connect with me on LinkedIn for any kind of curbside consultation or anything more formal, you are most welcome. And also, if you'd like to learn a little bit more about Collette Health from our website, please do look us up.
Yeah, I love that. I'll make sure to drop the curbside consultation. We'll try not to market that one too much, but I like that has a nice ring to it. Alrighty. Well, Christina, it was a pleasure speaking to you, and thanks so much for being a great guest on the podcast today.
Thank you too. It was my pleasure.